Hi everyone, my name is Fajgenbaum. I'm a third-year medical student from UNC Chapel Hill. I'm here today to talk with you about a project that I worked on with Dr. Syed about intralesional triamcinolone, looking at its efficacy in treating acute HS lesions. I have no disclosures. So at the end of this presentation, hopefully you'll have a better understanding of the role of intralesional triamcinolone in treating acute HS. This is some of the first data out, so hopefully you can use it to better guide your treatment. To give you a little bit of background, intralesional triamcinolone is used for lots of dermatological conditions like keloids, discoid lupus, and alopecia. People have been using it for HS nodules as basically a standard of care, very commonly used, despite its limited clinical trial data that's out. While we were working on this project, a prospective case series released its data, and it suggests that intralesional triamcinolone may be useful. It said that it decreased pain and decreased inflammation over a 7-day period, but it showed no dose-dependent effects. Other studies have shown the natural course of the lesion is about 7 days. So our primary aim was to determine the days of resolution of HS lesions that are treated with intralesional triamcinolone versus normal saline. In order to assess this, we looked over a 14-day period. We had a survey that asked patients to note when their lesion completely responded. And to have responded, basically that means to have returned to baseline. So back to where it wasn't as inflamed and the pain was gone. Our secondary aims were to compare the lesion pain reduction at day 5. Specifically, we were using standardized surveys and looking at a pain scale of 0 to 10, with 10 being the most pain that someone has ever had from an HS lesion, and looking specifically at day 5, once again with 2 different concentrations of intralesional triamcinolone and normal saline as placebo. Our other secondary aim was to compare patient satisfaction with treatment at day 14. Again, this was on the standardized survey, asking patients how helpful they thought the injections were. So for our hypothesis, this is something that at UNC Dermatology is used very frequently, something that lots of patients think is very useful for them and they actually come in asking for. So I was just curious who from the audience, as a very common, uses intralesional triamcinolone for acute HS lesions, or if you're a patient, if you're someone who thinks that this works for you. Okay, so it looks like a lot of you had the same thoughts that we did, which was that intralesional triamcinolone was helpful for HS, that it would reduce pain and that it would decrease the days to resolution. We also thought there might be a dose-dependent effect and that higher concentrations would reduce pain more and accelerate the resolution. So in order to address this, we had a randomized double-blind placebo-controlled trial. We were comparing 0.1 milliliter injections of triamcinolone 10 mg per ml, triamcinolone 40 mg per ml, and normal saline. Overall, we had 32 patients enrolled for a total of 67 lesions. Patients were able to get up to 3 lesions injected. And we used self-reported outcomes on the standardized surveys that I spoke about, and we analyzed them using p-values and 95% confidence intervals. So here's an example of typical HS lesions that we would inject for our for our study. There are discrete nodules. We like to do them about 5 centimeters apart so we didn't get a field effect, but in general these are typical. Well, my picture's not showing here, but what is supposed to be there is another nodule that's discrete in the axilla, also a large inflammatory sinus, to demonstrate that if there's a large inflammatory sinus and a region is largely inflamed, we would not have injected that. It would have been really hard to tell if there was resolution and if a patient had gotten improvement. So for the results, for days to resolution, there was no significant difference between groups. You can see that the confidence intervals are widely overlapping. The average days to resolution was about 10 for all groups. And then for pain reduction at day 5, once again, there was no significant difference between groups. This was using the 0 to 10 pain scale, and it was about 2 points on the pain scale that was decreased for all of the different groups. So in looking at satisfaction at day 14, once again, no significant difference between groups, and all of the groups found it a little bit helpful to moderately helpful. And here is a trend of the pain scores averaged at each day that they were asked, which they were asked at all of the days listed, to list their pain scores 0 to 10. And as you can see, they all basically followed the same path and there's the same trend despite what they were injected with. So overall, there was no significant difference using patient-oriented outcomes in terms of pain, days to resolution, and patient satisfaction. The average duration of lesions shown in this study was about 7 to 10 days, which is very similar to previous studies of lesions that weren't even injected. The discomfort, side effects, and cost of intralesional triamcinolone may not be justified for all based on these results. So why didn't it work? It works for lots of other dermatological conditions that are associated with inflammatory conditions. Well, maybe it causes trauma and irritation. Despite the fact that the steroid is useful for the HS, the trauma and irritation caused by the needle poke counteracts that. Maybe this doesn't reflect a real practice. We had one single injector, and they were using one single technique, so that may be different among providers. Another thing is the volume. We use 0.1 milliliters. Maybe they need to have a larger amount injected. And then also the number of injections. Like I said, we only did 3 injections per patient, and we like to do them far enough apart where we couldn't get a field effect. In real practice, providers may be injecting up to 15 in an axilla, and you may getting a field effect of the steroid, more typical of a systemic steroid effect. And lastly, maybe HS just is not responding to these steroids. So what should we do next? It looks like we need to have a larger trial with more lesions enrolled, and also one with more providers. That way we can have a more reflective approach that shows difference in techniques. It would also be useful to have a longer follow-up to see if there's difference in recurrence rates among the normal saline versus the intralesional triamcinolone. And also, it would have been useful to have documented how many days these nodules had been present before we injected them. When patients came in, we did ask for a newly inflamed lesion, and so it did seem like it had just popped up that day, maybe the day before, something newly inflamed that could resolve, and we did tell them to just count it as resolved when it turned to baseline, because sometimes the region has changed based on the disease and the scarring, but I think it would be helpful to see when exactly these lesions had popped up. So the takeaway messages, contrary to our expectations and maybe many of yours, intralesional triamcinolone, which is used so commonly, did not show a significant difference when we were injecting 0.1 milliliters. And this is something that patients do tend to find helpful, and as you saw, patients with placebo and with intralesional triamcinolone saw it was a little bit to moderately helpful, and some patients may come in requesting these. Ultimately, I think it will be left up to the provider. They should be to use the patient preferences and their clinical judgment when deciding which patients should receive these injections. And I'm just curious, after hearing this presentation, I know it's a little bit controversial because many of you said that you do use these regularly. If people would like to do a show of hands of maybe that you will consider this data next time you have patients coming in asking for these injections. Okay, so some people. Not much data is out there, but I'm pretty confident in our data, and I think that there isn't much of a difference. So I just wanted to thank you all for having me here, and a special shout out to Dr. Syed, who's worked with me for a while on this project. I really appreciate it. Thank you.